rather than a COVID agenda. So a lot of cynical minds suggesting that there is a political or an economic or some other agenda going on.
I see. Yeah.
You know, so the places which have been put in the high tier and been told to do a lockdown, they are all labor-dominated places.
I see. I see. So
So
there seems to be a party bias, actually. Interesting.
So yeah. So that's sort of, but we don't know for sure.
Yeah.
Yeah. Good morning, Professor Marco.
Morning. How are you?
Yeah, good.
Ishran, good morning.
Morning,
Marco. Good morning.
Hi, Marco.
Hi, how are you?
So everybody joined. I think Oscar Del Bruto will join soon, or maybe later, and Christina Mara is yet to join. But anyway, we'll start at sharp 6:30.
Okay. I suppose that one of the issues with Dr. Mara is that her time zone is pretty tough because I mean, it's very early in the morning, I suppose, for her. So it should be difficult, really. Marco, how is the situation in Honduras?
Actually, we have a reduction of the pandemic. We are having about 80,000 people infected by COVID and about 2,500 people that died during this pandemic. So we are just trying to, as everybody else, trying to open our economy, but it's getting a little bit difficult. Yes, that is the situation in our country at this moment. I know that Brazil is having a lot of problem, and also in England, UK, and you know, everybody else around the world. Yeah, it's not easy.
But you have to remember that the last pandemic, with the Spanish flu, it lasted 3.5 years. Right. So it's not a surprise that this will go on for a couple of years at least.
I agree.
Before things become normal, it's going to be some time.
Yeah, there is a prediction that it will go off in 2025. Eventually, I mean.
Yeah, well.
This is becoming very depressing, really.
Is that after Trump has finished his second term?
That's right.
Don't say that, Kailash.
Yeah.
Hi, Charu.
Hi, how are you?
Hi, Charu.
Yeah, good to see you.
Hello, Charu. How are you?
Hi, how are you? Thanks for accepting this invitation.
No, my pleasure. My pleasure. Thank you.
So how is the COVID in Brazil?
We were talking about that. In fact, the situation is improving.
Okay.
Surprisingly, I must say, not clear why, because since the very beginning, our government, as everyone knows, has not been firm in enforcing social distancing and other measures. But the reality is that probably as sort of internal dynamic of the pandemic, the situation is improving substantially.
Okay. No, it's not improving here.
Yeah.
Right.
Dr. Mara is on.
Rahul, have you joined?
Yeah.
Yes, sir, I've joined.
Yeah, Christina is here.
Yes,
hello, good morning.
Yes.
There she is.
Oscar is not around.
Yeah. Oscar, maybe he will join late.
How is the situation in Pune, Rahul? COVID situation?
Getting better, but still, currently this week I am on the COVID duty. I just finished
the rounds from the COVID
the meeting. Yes.
Yeah.
But things are getting better, hopefully.
Yeah, we have some beds vacant today, which has never happened in the last month. So I
Fantastic. Great.
Yeah, Professor Christina, good morning.
Good morning, and it's very early for me.
I was telling them, it's tough on you. Yeah.
Tough,
morning, Christina.
Yeah. What's the time? Chico?
It's 6 a.m.
You can open the room now, and we'll start at 6:30. It's now 3 minutes to 6:30.
Okay. Just let me know when I have to share my screen, please.
Yeah. Dr. Kailash will introduce you, and once he introduces you, then you share the screen and speak.
Thanks.
Kailash.
Sure. Tell me when I'm ready to go.
Yeah, sure.
Okay. Meaning ready to start.
Nancy, you can open the room now.
Yes, that is what I was going to ask you. So we have 2 more minutes.
Yeah, you can.
Yeah, you open the room and
6:30 actually.
Yeah, it's we can start now.
No, another 3 minutes there.
2 minutes, yeah.
Mansi, open the room. And
yes, sir, I have opened it.
Yeah.
Why is it half 6:30 there when it's 6 here? How does that happen?
Yeah, it does happen.
It happens in Burma as well.
So,
must be very confusing.
Yeah, what the timing you said?
Yeah, I mean, it'd be off by a half hour. Could be different by a half hour. I didn't know that time zones broke up into half-hour increments.
Do we start, sir?
I think so. Rahul, you start.
Yeah. So welcome everyone. Welcome to the second series of World Federation of Neurology Neuro-Infection series. And we are going to have an interesting session this time. And let me invite Dr. Meshram to start the proceeding of this meeting. Meshram, sir, you can start.
Thank you, Rahul. Dear friends, buenos dias, good morning, good afternoon, good evening, bonjour. On behalf of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology, Indian Academy of Neurology, and Forum for Indian Neurology Education, I welcome you all for this third session of WFN Neuro-Infection Series 2. Today we have 2 talks and 2 cases. I welcome the eminent speakers, Professor Francisco Cardoso and Professor Cristina Mara, and the chairs, Professor Kailash Bhatia and Professor Ricardo Nitrini. This session is organized by Pan American Federation of Neurological Sciences, and moderator for the session is my friend, Professor Marco Medina. Professor Marco Medina is the Professor of Neurology and Epilepsy. He is the former Dean, Faculty of Medical Sciences, National Autonomous University of Honduras. He is Director, WHO Collaborating Center for Research and Community Intervention in Epilepsy. He is very active in WFN, an active member of Tropical Neurology Group. He is a Regional Director for Latin America for WFN. He is President of Pan American Federation of Neurological Science Societies. He had 150 publications, 26 chapters, and 7 books. He's a fellow of American Academy of Neurology, American Neurological Association, European Academy of Neurology. He is on editorial board of Journal of Neurological Sciences and Epilepsy Open. His areas of interest are neurology, tropical neurology, public health, epilepsy, clinical neurophysiology, and genetics. He received various honors. In the room, we have case presenter, Professor Oscar Del Bruto, who will join soon, and Dr. Larissa Silva Texera. I welcome them. And then IAN Secretary, Dr. Gagandeep Singh, Dr. Rahul Kulkarni, who is moderator for Asia-Oceania region, is a convener of Tropical Neurology subsection of Indian Academy of Neurology, and he's active member of Tropical Neurology Group of World Federation of Neurology. I welcome you all. I'm sure you will enjoy this session and the series. We also have Dr. Charu Shankla, and I welcome Dr. Charu. Now I hand over to Professor Marco Medina to carry out further proceedings of this very important session. Thank you very much.
Professor Chandrasekhar Mishran, this is a great honor for the Pan-American Federation of Neurological Societies to introduce the two chairs of this important session. We are very pleased to promote with Professor Mishran this important conference. Professor Kailash Bhatia is a professor of clinical neurology at the Department of Movement Neurosciences at the Institute of Neurology, University College of London, Queen Square in London, the UK. He's associated editor of Movement Disorder Clinical Practice Journal, and he's a fellow of Royal College of Physicians and corresponding fellow of the American Academy of Neurology and the American Neurological Association. He has over 500 publications, and he's the chairman of the Movement Disorder Subcommittee of the European Academy of Neurology, and has served on various subcommittees on International Parkinson's Disease and Movement Disorder Society. Welcome, Professor Bhatia.
Thank you very much.
Also, we would like to introduce Professor Riccardo Nitrini. Professor Riccardo Nitrini, he's a professor and head of the Department of Neurology and Behavioral and Cognitive Neurology at the unit of the Department of Neurology and the Reference Center for Cognitive Disorders in the University of Sao Paulo Medical School, Sao Paulo, Brazil. He was graduated in medicine in the University of Sao Paulo Medical School in 1971, and he made his residency program in neurology in 1974, obtained the degrees of Master in Science in 1981 and Philosophy Doctor degree in 1986, for both with thesis on neurosyphilis. He's an associate professor of neurology, and recently in 2012, he became a full professor of neurology in all the departments of neurology in the University of Sao Paulo. The current areas of research of Professor Nitrini is on dementia, including epidemiology, clinical diagnosis, neuroimaging, pathology, and treatment. He's author of 353 papers, PubMed Index journals, 25 books, and around 130 chapters in books. He's the founder and editor-in-chief of Dementia and Neuropsychology, and a member of the editorial board of Alzheimer's disease and associated disorders, Archivos of Neuropsychiatria, and Journal of Alzheimer's Disease. Welcome, Professor Ricardo Nitrini.
Thank you, Professor Marco. I would like to also welcome Professor Raj Shakir, former president of WFN, Dr. Pramod Kumar Pal, president of Indian Academy of Neurology, Professor Saroj Katrak, Professor Joe Berger, and Professor Steve Lewis. Welcome you all. Now I request Professor Kailash Bhatia to introduce today's speaker, Professor Francisco Cardoso. Kailash.
Thank you indeed for inviting me. It's a real honor and privilege for me to introduce Professor Francisco Cardoso. He's a professor of neurology at the University of Minas Gerais in Brazil. He's published more than 200 peer-reviewed papers, and he's the president-elect of Movement Disorders Society. For us in the movement disorders field, we fondly call him Chico. Chico has made an enormous contribution to the field of movement disorders, particularly in Sydenham's career and other conditions. And he's really on the forefront of the movement disorder field, and it's really remarkable that he, coming from Brazil, has contributed so much to the field, and he has indeed become the president-elect of the International Movement Disorder Society, and I think it's an amazing achievement. He's going to talk about movement disorders of infections, and this couldn't come at a more appropriate time given the pandemic which we are all facing. Infections and pandemics don't know any boundaries, and I'm sure what he has to tell us about movement disorder and infections will be important for all of us. So Chico, a great pleasure to have you on this forum, and we look forward to your presentation.
Thank you very much, Kailash, for this very kind introduction. And this is actually, most of these words, they are a result of our friendship rather than any concrete thing. So I'm also very honored to be in this forum, and it's a great privilege. And I would like especially to express my acknowledgement to Charu, who has been a close friend for many years, and also to Dr. Meshram for having organized this invitation and this session. So as Professor Bhatia has said, I will describe in these next 30 minutes movement disorders associated with infections, and of course that given the current situation of COVID-19, I will dwell sometime on the possible relationship between this emerging condition and movement disorders. Let me move this forward. Okay, no disclosures related to this talk. So that's the outline of my presentation. So it will be a broad overview of movement disorders related to infections, but I will not actually mention, because of the next talk, on syphilis, which has also some interface between infections and movement disorders. So let's get started with a historical note that, as I will have chance to go back to this issue in the end of the presentation, it may well be relevant to the current situation. So post-encephalitic Parkinsonism was probably the first well-defined movement disorders associated with an infectious condition. So this was described by this gentleman. He was from Austria, but had a Greek background, Baron Constantin von Economou, and sometimes this condition is referred as von Economou encephalitis as well, encephalitis lethargica, in the beginning of the 20th century. Interesting that the etiology of this condition, although most people believe that it was related to a viral infection, but it has never been, in fact, established And after an acute phase where patients usually had a decreased level of consciousness, sometimes they would in fact develop movement disorders, especially hyperkinesias of the face. Some of the survivors, after some time, they would develop Parkinsonism with a very slow, if any, progression, but with some interesting clinical features. One of them was the presence of ocular crisis. And by the time that levodopa became available and some of the survivors of this condition were still alive, and when treated with this drug, uh, they actually displayed an exquisite sensitivity with the development of severe dyskinesias. And this was, in fact, very well described by the late Oliver Sacks in his book, Awakenings. But I will ask you to keep this lesson in mind, the possibility of one infection leading to a real well-defined movement disorder, because this may well be relevant to COVID. But before we go to COVID, so let's go over some examples of movement disorders associated with infectious disease. Let's get started with parasites. Neurocysticercosis is certainly the most important one in this particular area, because the larval phase of Taenia solium in the CNS is the most common parasitic disease worldwide involving the central nervous system. For instance, for us in Latin America, perhaps up to 15% of the population actually has neurocysticercosis, and this is common also in other areas of the world, like the Indian subcontinent, for instance. And as a result of the increased mobility prior to the COVID-19 epidemic, this was becoming also common in some other areas, like in the US. Movement disorders, they are, however, very uncommon in neurocysticercosis. Most patients, when they had an issue in this area, they develop Parkinsonism as a result of hydrocephalus usually, but sometimes they actually could have hyperkinesias, like this patient that we saw many years ago, more than 2 decades ago. As a matter of fact, we can see on the right-hand side that there is a classical image of cysticercus, and contralateral, the patient had a combination of some dystonic posturing with some chorea as well. After treatment of this neurocysticercosis, the patient actually displayed some improvement. Another interesting case who was also seen many years ago, and one was this woman with a hemifacial spasm related to a giant cyst in the posterior fossa. One of the interesting points that this condition, despite the fact that it remains quite prevalent in Latin America, but there has been a decrease in the frequency as a result of public policies of treatment of cysticercosis and Taenia in general. How to manage these patients? Regarding the movement disorders, it's essentially the same strategies that we use for the movement disorders unrelated to this particular condition. So, for instance, antidopaminergic agents for chorea, botulinum toxin injections for the hemifacial spasm. But sometimes patients may require surgery when they have symptomatic hydrocephalus. And if there is a giant cyst or several cysti with mass effect, they may require surgery. It's a sort of controversial issue if patients must be treated or not with antihelminthic drugs. And we have in this session Dr. Del Bruto, who has made substantial and meaningful contribution to this field. But overall, physicians tend to treat these patients. But one word of caution, that sometimes when we do use these medications, we may induce death of a substantial number of cysts, and this may lead to acute inflammatory response, and that's why sometimes physicians have as a practice to associate these treatments with steroids. Speaking of protozoans, malaria is, unfortunately, and it remains a condition which is endemic in large parts of the world, and it's a cause of major disability. And regarding movement disorders, the issue is usually related to cerebral malaria, which is quite common, unfortunately, in Africa, and it hits particularly the pediatric population. So patients, this is related to Plasmodium falciparum infection. These numbers are astonishing. So every year, there are more than 500,000 cases of cerebral malaria in the world. I suppose that the scientific community doesn't speak much about that. So it's a sort of silent endemic that is really targeting many disabled people. And patients, they may actually have coma, seizure, intracranial hypertension, upper motor neuron syndrome. So it's a quite a large number of neurological issues. And in terms of movement disorders, what has been most commonly described are ataxia, tremor, and dystonia. Interesting that despite the fact that this is common and this is well known for a long period of time, but it's not clear the underlying mechanism. One of the possibilities that this would be related to a vascular issue, but there is increasing evidence that, as a matter of fact, this might have an underlying immune process that would lead then to a vascular problem resulting in these neurological features, including movement disorders. Regarding bacteria, tuberculosis is also another perhaps neglected condition, which remains common in many parts of the world. And it's interesting that at the height of the HIV/AIDS pandemics, tuberculosis became quite commonly associated with HIV infections. But right now, in many parts of the world, including in Latin America, there is a clear dissociation between these two conditions. First, because HIV infection, fortunately, has undergone a decrease in its frequency. And secondly, patients who are previously immunocompetent, they still are affected by tuberculosis. To my knowledge, the best description of movement disorders related to tuberculosis was published by Fernando Alarcón from Ecuador, from Quito. And Fernando, he actually put together, along with some colleagues, including Eduardo Tolosa from Spain, 30 patients with meningitis. And he was able to describe that 1/3 of these patients, they actually had movement disorders. And usually there was an association with an underlying vascular disorder. It is well known that tuberculosis meningitis may lead to vasculitis, especially in deep-seated vessels, and this results then in vascular lesions in the basal ganglia that may cause chorea, dystonia, myoclonus, but tremor is actually the most common movement disorder in these patients. And unfortunately, because of this mechanism, ischemic lesion, the treatment of these individuals is quite challenging in terms of controlling these movement disorders. So usually patients remain with problems in this area. But what I would actually like to describe, and let me take the sound out of this, is Sydenham's chorea. Perhaps I have to correct myself because I said that post-encephalitic Parkinsonism was the first well-described post-infection movement disorder, but it's quite likely that, as a matter of fact, Sydenham's chorea was the first one, although the issue with the establishment of the underlying etiology was somehow slow to come down to streptococcus. And despite the decline worldwide of these cases, but it does remain as the most common cause of acute chorea in children worldwide. In addition to movement disorders, which surprisingly, given the underlying autoimmune mechanism related to circulating antibodies, in 20% of these individuals, it is a hemichorea, as we are seeing in these particular patients. In addition to movement disorders, patients also have non-motor issues. We and other investigators, we have described that there is a relationship with behavioral problems. Some of these patients, they develop obsessions, compulsions, and even a dysexecutive function, a dysfunction, as a result of probably a lesion in the connections or dysfunction of the connections between the prefrontal area and basal ganglia. But I'd like to draw your attention that the most disabling feature of Sydenham's chorea is a non-neurological problem, because as we know, this is a major a manifestation of rheumatic fever, and which is carditis, which can be found in up to 80% of these patients. So when we follow up the individuals with Sydenham chorea, it's absolutely mandatory to have a cardiologist also looking after these patients. The management is based on a combination of anti-choreic agents, and I will highlight that we and others, we prefer not to use neuroleptics as a first choice, because these patients are particularly susceptible to the development of extrapyramidal, so-called extrapyramidal side effects like Parkinsonism, acute dystonic reaction. So we usually prescribe anti-epileptic agents, although the level of evidence is relatively low, but valproic acid is usually quite effective for most patients. But for us who live in endemic areas, the crucial part of treatment is to place these patients on secondary prophylaxis, usually with penicillin, to make sure that they will not have a new bout of rheumatic fever, which may lead to an increased dysfunction of the brain and particularly of the heart. One final word about Sydenham chorea, which has been a contribution of our group as well, that if we do follow up these patients carefully, we can actually notice that 20% of individuals after 40 months of disease, they remain with chorea. It's not as severe as at the onset, but yet there is a persistent chorea, which indicates that this underlying autoimmune mechanism triggered by streptococcus, it may cause an irreversible dysfunction of the basal ganglia, something that it was probably relatively obvious given the fact that women who had rheumatic fever, especially Sydenham chorea, during childhood, when they become pregnant, they may develop the so-called chorea gravidarum, which is a recurrence of chorea triggered by the hormonal changes associated with pregnancy. But let's concentrate now the second half of the talk on virus, because probably in terms of movement disorders, these are the etiological agents more commonly involved. Herpes encephalitis is claimed to be the most common sporadic form of encephalitis worldwide. And this patient on the left-hand side, he had the classical acute form of this condition, and he was left with this as well, very typical lesion in the pole of the temporal lobe. But he was left with a combination of dystonia and also some bradykinesia. We can actually see that he is slow, and it is controversial if this is true Parkinsonian bradykinesia or simply a slowness related to a more fixed dystonia. But the fact is that this patient had a lesion of the contralateral basal ganglia. This is something that sometimes can be seen in herpes encephalitis. But what is actually more interesting is the possibility of the encephalitis leading to a formation of anti-NMDA receptor antibodies, which then will cause chorea. This was found in this very interesting boat-centric Spanish study by the Dalmau group in Barcelona to be present in 64% of these individuals who had this post-herpetic encephalitis chorea. 1/4 of patients approximately who have this acute encephalitis, they have this chorea. It's usually 2 months after the acute episode. In the past, physicians tended to believe that this was a result of a reinfection. But as a matter of fact, this is not related to a direct action of the virus, but it is an autoimmune condition that in children is usually characterized by chorea and orofacial lingual dyskinesia. And in adults, in addition to chorea, behavioral findings are really severe sometimes. And the management is not to do a new treatment with antiviral agents, but it's actually to do immune suppression. And in this Spanish series, they reported that patients who are very young, in this case 4 years or less, they actually have a worse prognosis. So this is an interesting condition which is related to these antibodies. But in terms of epidemiology, and that involves not only the Americas, but also the Indian continent, Africa, so this is a global issue, it's the flavivirus family. In the US in particular, West Nile virus is the most common arbovirosis, and it's transmitted by colics. And one relatively old study reported that almost 100% of these individuals during the acute phase, they actually have a movement disorder, usually tremor. But right now, especially in Latin America, but as I have chance to show in some other parts of the world, in Asia as well, in Africa, so these 3 conditions, dengue, Zika, and chikungunya, they are the most important diseases belonging to this particular viral group. So these viruses, they are transmitted by mosquitoes, Aedes. And when it comes to movement disorders, they are not common, but almost invariably, they are associated again with an induction of an autoimmune process. So some of these individuals, they have cerebellar ataxia, and others opsoclonus myoclonus ataxia syndrome. But I have actually to say a few words about Japanese encephalitis because this is the most common endemic encephalitis worldwide, and it's a big health issue in Asia, despite the name Japanese, but as a matter of fact, as far as I am aware of, the largest brunt of this disease takes place in the Indian subcontinent. And some of these individuals, and there are several reports, including with video recording, they may actually develop Parkinsonism and dystonia, and it's usually symptomatic management. Just for you to have an idea of the importance, growing importance of this condition, so I will briefly make a few comments about epidemiology. So that was the situation of dengue in the Americas in the beginning of the 1980s. So essentially, we had very few cases, and there has been, unfortunately and sadly, a growing increase in the frequency. And as of now, every year during our summer, the summer in the Southern Hemisphere, we have millions of cases. So despite, with several deaths actually. So despite the fact that movement disorders are not common in these people, but when we take into consideration the extremely large number of people who are affected, so it's not a negligible number of movement disorders in this condition. So it's the same with Zika. Zika was infamously known as a cause of an epidemic of microcephaly in Brazil and in Colombia in particular, but also in some other parts of the world. But other other neurological issues such as Guillain-Barré syndrome and also some other immune-related movement disorders, they may happen. What I'd like to highlight here that this is, again, an issue which is relevant to Asia. It's also common in Europe. And as a matter of fact, Zika is the name of a forest in Uganda where this virus was first identified back in the 1950s. And chikungunya is a word used by people in the northern part of Mozambique, which means pain, to bend in pain. This is a quite painful condition that sometimes it may actually lead to movement disorders. And again, this is there is a march to take over the whole world, including North America and in Europe as well. There are reports of these conditions. Você consegue sentar? To HIV. HIV, prior to the development of these highly effective antiretroviral therapies, patients were really extremely susceptible to opportunistic infections, like this patient who had the typical lesion of toxoplasmosis. And as a result of that, she had hemichorea, less than hemibalism. At that point of the HIV/AIDS pandemic, almost 3% of individuals who tested positive, they actually had this condition. But with the development of these more effective treatments, the phenomenology of movement disorder associated with HIV has changed. So right now, what we is more individuals who actually have autoimmune conditions. So this unfortunate child tested positive for HIV and developed this classical opsoclonus. It's the unforgettable, unfortunately, picture. So these very rapid, conjugate, random, chaotic movement disorders, also with some myoclonus and some cerebellar ataxia. So that's probably the most common movement disorders seen right now in the context of HIV infection. So this slide somehow summarizes what I have already said. So it's an autoimmune phenomenon, what we are seeing right now, and the treatment is basically symptomatic, targeting the phenomenology that these patients develop. But let's spend these last minutes of my talk describing what has been talked about the relationship between COVID-19 and movement disorders. There are a few reported de novo cases of movement disorders, and one may argue that it's not really a few cases, but when we take into consideration the extremely large number of patients with COVID-19 worldwide, as a matter of fact, at least what has been reported and what we see in practice, is not a large number of cases. But of course, if someone has, let's say, Parkinson's disease and does have an acute COVID-19, this may lead to a worsening of these, sometimes temporary worsening of a pre-existent condition. And there was an issue that Professor Bhatia and myself were talking about before the beginning of this webinar, that one of the problems that COVID-19 has caused worldwide is difficulties to access healthcare. Most resources, they have been channeled towards providing care to COVID-19 disease. And so patients, sometimes they were left without the required healthcare, including movement disorders. So, but when it comes to why is these patients, they may actually develop movement disorder, there are several which are not excluded among themselves possibilities to explain why they would develop movement disorder. One of them is direct invasion of the CNS. There is, I suppose, undisputed evidence as of now that the virus can actually be found in the brain. But most likely, autoimmune process is one of the potential and perhaps one of the most important mechanisms, and also the so-called cytokine storms. So the patients, they develop a severe, a massive inflammatory reaction leading to damage of several organs, including the brain as well. And there remains this issue of post-encephalitic degeneration, which takes us back to the phonoeconomoencephalitis that I started my talk with. So this is, of course, because it's perhaps too early to say, but there are there is a lot of speculation right now if somehow this acute condition could not lead in a long run to the development of a post-encephalitic degeneration as it was seen with the von Economou disease. Well, we have prepared this review of the literature up to 7 days ago, and we have submitted this, myself and my colleagues. And this is a list of cases of movement disorders associated with COVID-19, which have been published so far. I do not have time to go over all the details of this table, but what I would like to highlight that it's certainly fair and safe to say that myoclonus is the most common movement disorder that has been at least reported and seen in these patients. So the underlying mechanism would be probably as a result of a diffuse encephalopathy. This is a classical feature of encephalopathies to develop myoclonus, but there are some other autoimmune conditions like ataxia, opsoclonus, myoclonus, with some variations, for instance, ocular flutter, which is a condition very close to opsoclonus, ataxias, and so on. But I would like really to finish my presentation showing this patient of ours. She was reported and published recently in Movement Disorder. This woman, she had a very mild acute COVID-19 form without any evidence of encephalopathy. But by the time that she was recovering, she actually developed this clinical picture. As everyone can see in this video, she was severely bradykinetic, but not only that, as a matter of fact. So at least our interpretation of this right hand, that she, in addition to having perhaps some dystonic posturing, she clearly had apraxia of this right hand. And she was, I would say, well worked up. And in addition to dysfunction of the pre-synaptic form, presynaptic part of the nigrous striatus system, which explains why she has become responsive to levodopa. So 2 weeks after she was started on 200 milligrams 3 times a day of levodopa, she actually improved substantially. But she also had some evidence of cortical dysfunction. So there remains the issue if this is an exception of more people will actually develop a similar condition, which is unrelated to an encephalitic process as well. But clearly she was Parkinson and she remains responsive to levodopa, but let's see how she will fare in a long run. So finally, to finish my presentation, so I guess it's fair to say that all groups of microorganisms may cause hyperkinetic and sometimes even hypokinetic movement disorders. Neurocysticercosis remains as an important parasitic disease of the CNS. Sydenham chorea is decreasing in its frequency, but yet it is the most common cause of acute chorea in children. Virus in general, including SARS, coronavirus type 2, they can be associated with the induction of movement disorders. So, and finally, a word of acknowledgement to my associates down here in Belo Horizonte who have been very helpful in really putting together all these cases. So thank you very much for your attention.
Thank you very much, Professor Caruso. Is it time to take questions now, Chandrasekhar, or is it later?
No, take the questions now.
Okay. So there were a couple of questions, somebody asking about whether hypothermia, as you see in malaria, etc., whether that can cause a ataxic syndrome. But before we come to that, I just wanted to just pick your brains on the current COVID situation and the number of cases who have anosmia as a prominent feature. And despite that, the number of cases described with Parkinsonism, so far at least, are relatively few. So in your, I know it's difficult to predict, but in your view, in your if you're looking at your crystal ball, I think you were trying to suggest that it's unlikely that we will have cases of Parkinsonism as we saw in encephalitis lethargica with is that the sense we are getting from you, Chico?
I agree, Kailash. I believe that despite the temptation to compare the current situation with the phone economy disease, but I believe that we are dealing with two completely different conditions. One should not forget that every single patient, by definition, who had phone economy disease had encephalitis, and encephalitis is not really as common in COVID-19 as it was, of course, in the phone economy disease. That's the first point. The second point, that yet the fact that more than 80% of patients with Parkinson's disease, they may have as a pre-motor, pre-symptomatic feature anosmia or hyposmia. But the situation, in my view, in COVID-19 is different. Although 80%, there is this interesting multicentric European study reported that 80% of patients with COVID-19, they actually have anosmia, but most of them, after a few weeks, this actually disappears. So the olfaction becomes normal again, suggesting that perhaps this was a temporary inflammatory condition. So my personal view is that it's not very likely that we'll have something similar to what happened in the beginning of the 19th century. I don't know if you have the same feeling, so I'm curious to hear what you have to say about that.
No, I think I agree. Although it was a bit worrying, at least in the beginning, that it was so common. There are some cases who have persistent anosmia, so even up to 6 months or later, and some who have not recovered. So I think it'll be interesting to see what happens to those. So we need some follow-up studies. Too early to say anything, but I agree with what you're saying. That picture is very different. We have some more questions. I don't know how much time we have. Chandrasekhar, I'm guided by you. So you can tell me when. So Hadi Menji is on the line, and he also said that anosmia is reversible, so that's true. And he says, what about the evidence for pediatric encephalitis lethargica showed NMDA antibodies or basal ganglia antibodies? I don't know whether anybody knows about that. There was some paper from Russell Dale, I think, about a encephalitis lethargica case who had anti-basal ganglia antibodies, but I don't think it has been looked at systematically.
I agree, Kailash. If I may say just a few words, because somehow what Russell has done in the study, which was published in Brain, was really to try to find out streptococcus-induced anti-basal ganglia antibodies in these particular patients. But as we know now, these antibodies, they are quite non-specific. That's exactly one issue. And the second issue is that the clinical picture of these patients is quite different, honestly, from what was reported with post-encephalitic Parkinsonism. So I don't think that this is something that really is much relevant.
Yeah. And then there are some others asking about what is the role of immune therapy in movement disorders following COVID. Well, I think till we establish whether there is a truly immune-mediated process, because as Professor Cardozo pointed out, there are different processes possible. So immune therapy, I guess steroids are widely used, and I don't know, Francisco, maybe you can answer.
One of the issues that with this paper on the role of steroids in patients who are severely ill, so I suppose that every single center throughout the world has been really treating these severely affected COVID patients with steroids. So that leads really, my view, to difficulty in really dissecting which would be the role of these treatments, specifically for movement disorder. It does make sense, of course, from a speculative point of view, but there are no data really to support that.
I can make a comment. The Guillain-Barré syndrome associated with COVID is treated with intravenous immunoglobulins. We've had few patients. I think Rahul has had some patients of GBS.
Yeah, the question was whether movement disorders. So
yeah, I know, I know, but similar immune-mediated disorders. So that's the reason I thought I could talk about it. Post-infectious immune-mediated disorder, like
Dr.
GBS.
Joe Berger wants to. Sorry, Charuk.
Yeah, no, go ahead, please.
Yeah, I was just going to mention a few things. It was terrific talk. Thank you very much. With respect to HIV, I think that one of the things that needs to be emphasized is the frequency with which people can look Parkinsonian when they have AIDS dementia. And in fact, I've had the occasion of seeing patients who had been misdiagnosed by neurologists, not recognizing the patient was HIV infected, trying them on dopa drugs that did not work. These people are slow, they're bradykinetic, they have facial masking, they have slow thinking, and it could be mistaken. And interestingly enough, if you look at where the virus is in the brain in the highest concentration, it's in deep nuclear structures. And if you do FDG PET in these people, and we've done some of these studies, what you find is that initially there's hypermetabolism with the HIV infection in the basal ganglia, then it becomes hypometabolic. And there's a disruption of the blood-brain barrier that looks specific to the basal ganglia. And furthermore, if you look at dopamine levels in these people with HIV dementia, the dopamine levels in their spinal fluid are lower than what we saw in normal individuals. So Parkinsonism is actually a very common manifestation. We don't see it very much anymore because we're not seeing much in the way of HIV dementia, at least the advanced stages of it. But it can still be an issue. And the other thing that I would add to your talk is Whipple's disease, which is also an infectious illness and can present with movement disorders, facial myarrhythmias, and other issues. So we've certainly seen that. And we've seen that in HIV-infected individuals as well. Whipple's as a complication of HIV. I've also seen people that have had severe chorea that have turned out to be the consequence of HIV alone. They've come to autopsy, and what we found is just overwhelming HIV encephalitis. It's got to be very, very rare, but we've certainly seen that as well. So there's a spectrum of movement disorders we see in the setting of HIV. That's all I wanted to say.
No, thank you very much, Dr. Berger. I take all your points, and it's very true. And as a matter of fact, in the interest of time, I had to restrict my talk to a few issues, but there are many other infectious diseases that can also lead to movement disorders. For instance, perhaps a bit in the context of HIV, we have seen patients with cryptococcosis who actually develop Parkinsonism, and we have reported that some years ago in movement disorders. So there are other conditions, and Whipple's, despite the fact that it's a very uncommon condition, but it's an important consideration, of course, yeah, with brainstem lesion. Yeah, but thank you for your comments.
Sure.
Okay, I think there aren't any other comments. So thank you very much, Chico, and
thank you.
Thanks for your excellent presentation. And as you can see, there was a lot of discussion, so it was very well received.
Thank you. Thank you.
Thank you, Professor Kailash and Professor Francisco. And we'll have some questions after the second talk this time. And I request now Professor Ricardo Nitrini to introduce the second speaker, Professor Cristina Marra. Professor Ricardo.
It's a pleasure to present to Professor Cristina Marra. Cristina Marra is Professor of Neurology and Division of Infectious Disease at the University of Washington, Seattle, United States. Is Vice Chair in Academic Affairs of the Department of Neurology, University of Washington, also in Seattle. She is a member of the editorial board of MedLink Neurology, of the editorial board of Sexually Transmitted Disease. She had an Achievement Award of the American Sexually Transmitted Disease Association in 2014. She had 2,000 publications, 33 books, chapters, and 2 books. And Professor Maher is one of the most important researchers in the field of neurosyphilis in the USA and in the world. She also has relevant publications in HIV and nervous systems and other infectious diseases that involve the nervous systems. She also gave several lectures in many countries of the world. And we are very grateful for her to have accepted invitations for being in Brazil many times to share her knowledge with us. Thank you for accepting this invitation to participate in this session of the World Federation of Neurology, Neuro-Infection Series 2, which was organized by Marco Tulio Medina, who is the president of the Pan-American Federation of Neurological Science. Please, Dr. Maher, give us your talk, please.
Okay, well, Dr. Natrini, it's lovely to see you, even from afar, and thank you for the introduction. Let's see, I need to get this, there we go. Okay, can everybody hear me?
Yes.
Yes, yes.
Okay.
Go ahead.
Well, thank you very much for the introduction and for the opportunity to be here, even if it is pre-dawn where I am. Let's see if I can go forward. There we go. So I'm going to talk about neurosyphilis in the next half hour or so, and this is my outline. So we'll first begin with an overview of neurosyphilis, and in that I'll include ocular and otologic syphilis, even though these can be seen with or without neurosyphilis. Then we'll talk about host and bacterial risk factors for neurosyphilis. We'll say a few words about screening and a little bit about treatment. So just to give you a little background, some of the data I'm going to show you are from the University of Washington Syphilis Study, or UWSS, which was a study that was conducted in Seattle from 1996 to 2014. The entry criteria for the study were very simple. The patient had syphilis, and either they or their provider thought they needed a lumbar puncture to, hang on for a second, I'm going to fix this, to evaluate the possibility of neurosyphilis. I have to turn off my pointer and lower this. There we go. Okay. Where am I? Here I am. Okay. So patients, during this period of time, the CDC criteria for lumbar puncture changed, but overall, more people who had HIV were enrolled in this study. I'm having trouble with my thing here. Here we go. Pointer options, laser pointer. So people.
You could just use the arrows of front and back instead of using.
Yeah, if I use the arrows, I advance my slides accidentally. So this will work better. It's just I'm a little tripped up.
Okay, okay, all right.
Thank you. So people in the study underwent a standardized history and exam, a lumbar puncture, a blood draw, and if they were treated for neurosyphilis, they had follow-up visits at 3, 6, and 12 months undergoing the same procedures. This graph just shows you the number of people enrolled by year and number of participants on the y-axis by year on the x-axis. And what I want to point out to you, because it will become important later in the talk, is that we had people who enrolled for a first visit, shown in the dark orange, but we had people who came back with repeat episodes of syphilis, shown in the lighter orange. So of the people who enrolled in syphilis, we had 1,199 syphilis episodes in just over 1,000 individuals. And as I tried to point out before, 81% were persons living with HIV. So my overview of neurosyphilis begins here with a figure taken from a very nice paper by Khalil Ghanem and colleagues in the New England Journal of Medicine this year. This is an overview of all of syphilis, and I've just circled the neurosyphilis parts. So the first question I think we should ask is, what is neurosyphilis? So 40% of individuals who are infected with Treponema pallidum, subspecies pallidum, or T. pallidum experience CNS invasion, meaning that they have the organism identifiable in their spinal fluid. But most of these people, particularly those who are immune competent, will be able to clear the organism from CSF and will not have any further consequences. So that's invasion, and it's really not the same thing as infection. About 10% of those people will go on to develop early neurosyphilis, which can be asymptomatic or symptomatic. So asymptomatic neurosyphilis is defined purely by cerebrospinal fluid abnormalities, while symptomatic includes meningeal and meningovascular disease. Ocular syphilis can occur, and otic syphilis can occur separately or with neurosyphilis. Then some proportion of these individuals with asymptomatic, probably up to 30%, if untreated, will go on to develop the late manifestations of neurosyphilis, meningovascular disease, myelitis, general paresis, a rapidly progressive dementing illness, and tabes dorsalis, spinal cord disorder. General paresis and tabes are pretty uncommon in the current era. Notice also that otic syphilis and ocular syphilis can be very late manifestations. So these are the tertiary manifestations occurring 2 to 50 years after infection. Early neurosyphilis can occur within weeks to months to the first few years. So while we define asymptomatic neurosyphilis purely by CSF abnormalities, we define the symptomatic forms by the clinical findings plus CSF abnormalities. So symptomatic neurosyphilis, as I've just pointed out, can occur at any syphilis stage, can affect most nervous system structures, and it's typically separated into defined categories of symptoms and signs. So meningitis with headache and stiff neck, stroke. I don't need to tell neurologists about stroke, but I'll just point out that it's most commonly in the middle cerebral artery distribution, but can involve the posterior circulation as well. Dementia, we talked about general paresis, and then the spinal cord disorder of tabes with sensory loss, sensory ataxia, bowel and bladder dysfunction. So what do we do in terms of diagnosing symptomatic neurosyphilis? We talked about clinical findings and CSF. Neuroimaging can also be useful, and these are some examples. So this is an example of a person who has a CNS gamma. So a CNS gamma is really just a focal area of meningitis. You can see that there's enhancement along the surface of the brain and underlying edema. This person also has it, gamma. I don't know if you can see it because it's covered up by the Zoom part for me, but there's sort of a nodular enhancement over the surface of the brain. Again, a focal area of meningitis. And then this is an individual who presented with stroke, and you can, on this diffusion weighted image, you can see these small punctate infarcts. Typically, CSF has between 5 and 10 white cells in people living without HIV who have neurosyphilis. We use a higher cutoff generally in people living with HIV, 10 to 20 white cells per microliter of CSF, typically mononuclear, protein elevated, CSF VDRL specific but not sensitive, CSF FTA ABS sensitive but not specific, and then some more recent data suggesting that a CSF TPPA titer at or above 1 to 640 is specific and can augment the CSF VDRL. One thing I wanted to point out that's appeared in the literature over the last few years is syphilitic mesial temporal lobe encephalitis. This is actually a case that Steve Lewis may remember that was presented to me at his institution a few years ago. Subacute onset generally, although can be acute, cognitive and psychiatric symptoms. Almost all patients have seizures, they have abnormal CSF, and typically the MR shows what's shown here on the diffusion and the flare with increased signal in the medial temporal lobe. The differential here is obviously an autoimmune limbic encephalitis and HSV encephalitis. So remember to add neurosyphilis to that differential. I'll say a few words about ocular syphilis and then more about otologic syphilis. So ocular syphilis occurs at any syphilis stage, probably more common in early syphilis. Can affect more or most eye structures, but posterior and panuveitis is most common. And I had to look up what the components of the uvea are. It's the iris, the ciliary body, and the choroid. Typically, patients present with eye redness, eye pain, floaters and flashing lights. They can have vision loss, and in severe cases, blindness. Typically do okay if they're caught early, but not if they're caught late. And then otosyphilis can also occur at any syphilis stage, can affect most ear structures. Symptoms and signs include hearing loss, tinnitus, and vertigo. Typically, audiogram is said to show high-frequency sensory neural hearing loss. And again, both ocular syphilis and otosyphilis can occur with or without neurosyphilis. I'm going to show you some data that we recently published on otosyphilis out of the UW syphilis study. It turns out that there's really a dearth of literature on this form of neurosyphilis, or of complicated syphilis with or without neurosyphilis. And again, probably the largest and best series maybe included 12 patients with detailed audiometry. So in this study, we enrolled 394 patients in the hearing substudy, and they underwent portable audiometry, which was similar to the kind of audiometry you get in Oto clinic, except that it wasn't in a soundproof room. So it was conducted in a clinic. We included 329 individuals in the analysis. 65 were excluded because of pre-existing hearing complaints or missing data. So just to go over the methods a little bit. So this is an example of an audiogram, and we screened between 250 and 8,000 hertz in both ears, just air conduction. We only went up to 80 decibels hearing level. So anything that if the patient couldn't hear at 80, we just set them at 80. We didn't go into any higher decibel delivery, which can be done in a formal audiogram. So this is just hearing level, how loud the tone was, and then the frequency. So the person tells you at the lowest frequency at which they hear it, and normal values are less than 25. So this person is abnormal in the right ear and normal in the left ear. And then we made pure tone averages for the low frequency and for the high frequency. So the low frequency pure tone average was the average of 500, 1,000, and 2,000. The high frequency average was the average at 4,000, 6,000, and 8,000, again with a cutoff of 26 as being abnormal, so 25 or less being normal. So we defined hearing loss as unilateral or bilateral low frequency pure tone average abnormal. That would be low frequency loss. Unilateral or bilateral high frequency pure tone average above 25 decibels would be high frequency loss. And then if they had both, we said they had combined loss, which I called both on the graphs because it's shorter. So we also were able to categorize severity of loss. We could do it for both low and high frequency, although I'll tell you that few people had low frequency loss and few people had anything more than mild low frequency loss. So we couldn't really do a lot with low frequency loss, but we could with high frequency. And it was defined by the worst pure tone average of both ears. So normal, mild, moderate, moderately severe, and severe. And we combined moderately severe and severe together for the purposes of analysis. So this graph and wording shows you the main findings of the study. So while 22% of our participants complained of new hearing loss, 50% had objective hearing loss. As I said before, not much low frequency loss, mostly high frequency and combined. This graph is number of participants on the y-axis by low frequency alone, high frequency loss alone, or both. And the solid bar is unilateral, the hatched or striped bar is bilateral. And you can see that low frequency loss alone was largely unilateral, high frequency loss alone or combined loss was both unilateral and bilateral. and then making a lot of analysis condensed into a short couple of statements. These two tables show our findings. So this table is the adjusted odds of any hearing loss. This table is the adjusted odds of greater severity of hearing loss. So this is done by ordinal logistic regression, this by binomial. And you can see that detectable T. pallidum in blood, CSF pleocytosis, and increasing age all increase the odds of any hearing loss. They also increase the odds of greater severity of hearing loss. So again, detectable T. pallidum in blood, CSF white cells, and age all independently predicted either the presence of hearing loss or greater severity. And then in 33 individuals, we were actually able to look at hearing recovery after a neurosyphilis treatment regimen. Of the 33 who had any loss, 45% normalized. Of the 31 with any high frequency loss, 45% normalized. And of the 16 with any low frequency loss, 58% normalized, which is what's shown here on this Kaplan-Meier graph. So percent abnormal with everyone starting abnormal, and months after neurosyphilis treatment on the x-axis. The hazard ratios for normalization of any high frequency or low frequency loss were lower for older individuals, so about 5-fold less likely to normalize for those above the median age compared to below. And the hazard ratios for normalization of any high frequency loss was lower with higher severity and with CSF pleocytosis. Okay, so we've sort of covered some of the clinical manifestations. Let's move on to host and bacterial risk factors. One question that we wanted to ask was, do repeat syphilis episodes impact likelihood of neurosyphilis? Or another way of thinking about that is, does having syphilis more than once convey some sort of immunity? So for this analysis, we included 651 individuals. The index syphilis episode was defined as the most recent syphilis episode. So I showed you that people came back with syphilis episodes, but we also had access to the public health database and could pick up episodes that occurred before their first enrollment. We required that the study entry visit had to be within 30 days of the syphilis diagnosis date, which is what took our numbers down a little bit. And the total number of episodes includes the index episode. We looked for T. pallidum in blood and CSF by PCR and RT-PCR. And we defined neurosyphilis as white cells above 20 or reactive CSF VDRL. So this graph shows you the percent of participants on the y-axis and total number of syphilis episodes. So 1, 2, or 3 or more, and it's divided by stage. So late latent in the light gray, early latent in the dark gray, secondary in the black, and primary in the white. The number of individuals included is shown below for your interest. What we found was that the percent of individuals whose index episode was early latent was higher in those who had 3 or more episodes compared to those with 2 or less. But this was largely explained by testing frequency. So the more often you test, the more likely you are to find an individual who's asymptomatic. And then to again condense a lot of work into a slide, we found the detection of T. pallidum in blood or CSF or neurosyphilis was less common in those with previous syphilis. So that's shown graphically here, percent of participants on the y-axis, detection of T. pallidum in blood, detection of T. pallidum in CSF or neurosyphilis. In those without past syphilis in the white bars, with past syphilis in the black bars. And you can see that for all 3 of these outcomes, the percent of participants was lower when they'd had past syphilis. And then looking at the adjusted odds of all 3 of these outcomes, you can see that previous syphilis really influences how likely individuals are to have detectable blood T. pallidum, CSF T. pallidum, or neurosyphilis, anywhere from 2 to 10-fold less likely to have these outcomes if they had previous syphilis. As expected, if they were treated for their index episode before they entered, before they got their lumbar puncture, they were less likely to have T. pallidum detected in blood or CSF, also less likely to have neurosyphilis, although the impact was less. I point out to you that as we and others have published, RPR titer really influences whether you get neurosyphilis or whether you have neurosyphilis or whether you have detectable organisms in blood or CSF. And then interestingly, blood T pallidum, maybe as you would expect, was detected. The detection was more likely in people with early stage, but people with neurosyphilis were more likely to have actually late stage syphilis. So this points out the impact of RPR titer as well as the impact of previous syphilis. Moving on to other host factors, this was an analysis we did in 577 people living with HIV in our study. And again, I categorized patients by symptomatic, asymptomatic, or no neurosyphilis. Just showing you in terms of symptomatic, we had ocular disease, otologic disease, meningitis, and one patient with a stroke. And in addition to requiring compatible clinical findings, I also required that they had to have CSF abnormalities. For asymptomatic neurosyphilis, they just had to have CSF abnormalities. And for people who were normal, they couldn't have the CSF abnormalities. And what we found was that, again, serum RPR titer and late stage influenced the likelihood of neurosyphilis or the odds of neurosyphilis, but not using antiretrovirals was also a powerful predictor. So individuals with asymptomatic neurosyphilis were 2.6-fold, had 2.6-fold increased odds of asymptomatic neurosyphilis. People who were not using antiretrovirals had a little over 4-fold increased odds of symptomatic neurosyphilis. So host immunity makes a difference. And then what about bacterial factors? So I don't know if you guys know about this, but there are a couple of strain typing systems for T. pallidum, and this is one that we developed. It's called the Enhanced CDC Strain Typing System. All you really need to know is that there's 3 targets. This is the number of repeats in the ARP gene. This is an RFLP pattern for a family of genes. And importantly, the 3rd target is a sequence of the TP0548 gene. And just not keeping track of which is which, just if you notice here, this is number of individuals on the y-axis by year on the x-axis. And you can see that the pink strain predominated in Seattle through about 2004, and then the green strain came in. This is 14DF, this is 14DG. So again, differing by that 3rd target. What we found was that neurosyphilis was more likely when individuals were infected with a TP0548 type F strain. So again, that's that 3rd target of the strain typing. So here I'm just showing you the proportion of individuals with the reactive CSF VDRL who were infected with a type F strain versus other types. Doesn't mean you can't get neurosyphilis with other types, but it's more common if you're infected with a type F. And then I wanted to look and see if I could explain this away. So this is an adjusted model, including serum RPR titer, type F, and then I put in a variable for time just because as I showed you, the strain type seems to have changed, the circulating strain type seems to have changed around 2004. So I put that in. And still we find that individuals who are infected with a type F T. pallidum strain are about 3.5 times more likely to have a reactive CSF VDRL. So both host and bacterial factors influence whether people develop neurosyphilis. So let's move on now to the issue of screening, because if you read at least the CDC guidelines, they recommend lumbar puncture in individuals who have symptoms. So we wanted to look at how well neurologic symptoms predict neurosyphilis. So in this study, we included 385 people living with HIV, 81 HIV uninfected individuals, again in the UW syphilis study. They had to have no treatment before their lumbar puncture. We just defined neurosyphilis as, in my last slide, as a reactive CSF VDRL. All of our participants underwent a structured assessment of new symptoms that were rated as none, mild, moderate, or severe. And we excluded those with pre-existing symptoms and signs. And the symptoms we looked for were headache, stiff neck, photophobia, ocular inflammation, vision loss, hearing loss, sensory loss, gait and coordination. We did start to collect tinnitus later in the study, but I just didn't have enough outcomes to include it in this analysis. And again, combining a lot of analysis into a single slide, the first thing that we found was that there was no symptom that predicted the odds of neurosyphilis in the HIV uninfected group. But among the people living with HIV, at least mild photophobia, at least mild vision loss, or moderate vision loss even more, and at least moderate hearing loss, and at least mild gait and coordination, all significantly increased the odds of a reactive CSF VDRL. And in the people living with HIV in our study, the specificity of at least moderate symptoms from this list was 85 to 100%. It didn't mean that you couldn't have a reactive CSF VDRL without symptoms. That's the definition of asymptomatic neurosyphilis. But if you want to increase your likelihood of picking up people, you could look for these moderate symptoms. And then finally, what about treatment? So 2 questions I want to ask here are IV penicillin and IM procaine penicillin with probenecid, the 2 main regimens recommended by our CDC, are they equally effective? And are there alternatives to high-dose penicillin? So again, these are the CDC recommended regimens. So IV aqueous penicillin G, 4 million units IV Q4, or 24 million units a day as a continuous infusion for 10 to 14 days is the recommended regimen. The CDC says an alternative if compliance can be assured is IM aqueous procaine penicillin G, 2.4 million units plus 500 milligrams orally 4 times a day of probenecid, again for 10 to 14 days. And the CDC says that there are limited data and close follow-up is essential if you intend to use IV or IM ceftriaxone, 2 grams a day for 10 to 14 days. So we had looked at this early in our study when people were not on as powerful HIV drugs. So for this analysis, we included people who weren't in our previous analysis. So that was 223 individuals. 9 were excluded for having prior syphilis or not having a blood sample. To be in the analysis, they had to have abnormal CSF because we looked at normalization of white cells, protein, CSF VDRL, and serum RPR. And they had to be treated with a CDC recommended penicillin regimen. So the dose had to be correct and the duration had to be correct. And that left us with 118 who were treated with procaine penicillin and 32 who were treated with penicillin G. And I need to point out that we did not give the treatment in the study. So the treatment was chosen by the patient and the provider. Most of our participants were seen in our local STD clinic where IV penicillin was not an option for them. These are some of the characteristics of those treated with penicillin G versus aqueous procaine penicillin G with probenecid. You can see there's no difference in the proportion with HIV, no difference in their serum RPR titer before treatment. More patients who got aqueous procaine penicillin G had early syphilis, so primary, secondary, or early latent. And slightly more of them were treated before their lumbar puncture. That's really because people in our STD clinic are not allowed to leave the clinic without getting a dose of benzathine. So it was hard to enroll them before they were treated. CSF white cells were similar between the 2 groups. Protein was higher in the PEN-G group. I'm not quite sure what that's about, but that was taken into account in the analysis. And then the proportion with the reactive CSF VDRL was similar in the 2 groups. So this is, again, a Kaplan-Meier curve of percent abnormal on the y-axis by months after neurosyphilis treatment. Everyone begins or enters the study with an abnormality. And you can see that the CSF VDRL and the white cells in CSF normalized at about a year, as you pretty much would expect. But protein did not normalize over a year of follow-up, and other people have noticed that as well, or noted that as well. And then this is an adjusted hazard ratio table of normalization in the persons living with HIV. And you can see that CSF VDRL normalized more slowly, or it was less likely to normalize in people who had late syphilis, more likely in people who had symptomatic neurosyphilis, but importantly, more likely to normalize in people on antiretrovirals. And then the one unexpected finding in this study was that people who had a low CD4 were more likely to normalize their CSF white cell counts. And why might that be? So I'm just pointing that out again. And I think this gets to the issue of the influence of HIV on CSF pleocytosis. We know from other work that individuals with low CD4 are about 25-fold less likely to have CSF pleocytosis due to HIV. So I think in these people, their white cells were clearly due to syphilis. In people who had higher CD4s, the white cells in their CSF were probably a combination of CSF white cells due to syphilis, CSF white cells due to HIV, and penicillin's less likely to have an outcome in those, a measurable outcome in those individuals. I think this is a problem with neurosyphilis diagnosis in people with HIV that we're going to be faced with as more people are treated earlier and have higher CD4s. And finally, are there alternatives? What about ceftriaxone? So this was a Cochrane review that was published in 2019, looking at antibiotic therapy for adults with neurosyphilis. They reviewed the literature from 1946 to April 2019. And long story short, they found one paper that met their criteria for inclusion, which happens to be one that I wrote. So this was pretty embarrassing. That's me right there. So this was a pilot study evaluating ceftriaxone and penicillin G as treatment agents for neurosyphilis in HIV-infected individuals. And we found that they were, the two regimens were equivalent, particularly in people with early syphilis. But the Cochrane review concluded that the evidence was not clear and precise to support ceftriaxone for neurosyphilis, couldn't support or refute the regimen, and the benefits to people without HIV and ceftriaxone's safety were unknown. I will point out that there's actually never been a randomized controlled trial of neurosyphilis treatment of any sort. And it's really been based on clinical experience. And the clinical experience, I think, is pretty compelling that ceftriaxone is a viable alternative. So I've told you a lot, and I thought I would try to summarize it here for you. So we began with an overview of neurosyphilis, and I pointed out to you the issue of mesial temporal lobe encephalitis as sort of a new syndrome that doesn't really fit into those four categories that we talked about for neurosyphilis. We briefly talked about ocular syphilis, and then I showed you our data on otosyphilis, that screening with symptoms misses cases. Otosyphilis is more common and more severe with detection of T pallidum in blood and when there's CSF pleocytosis, more common in older individuals, and normalization is less likely with older age, greater severity, and CSF pleocytosis. We talked about host and bacterial risk factors, that previous syphilis protects against neurosyphilis. There's a higher risk for neurosyphilis in untreated HIV, higher risk for neurosyphilis with higher serum RPR and with certain strain types. We talked about screening with symptoms and showed that there was high specificity of at least moderate symptoms in persons living with HIV. And then we talked about treatment, that neurosyphilis treatment outcome was not different for penicillin G and aqueous procaine penicillin G. I didn't say this before, but it was regardless of HIV status. That we found the opposite of the expected relationship between normalization of CSF white cells and CD4. I think this is due to imprecision in neurosyphilis diagnostic criteria due to HIV-related CSF pleocytosis. And then finally, I pointed out to you that there's a lack of randomized trials for any alternative regimen or any regimen for neurosyphilis treatment. I want to acknowledge the people who've done the work in my lab over the years. And I think that's my last slide. So I'd be happy to take questions.
Thank you very much, Professor Maha. It was very nice to hear from you. We have a few questions from the participants. The first one is since neurosyphilis can be asymptomatic, should we ask for lumbar puncture in all patients with syphilis?
That is a great question and a true topic of debate. So the CDC here does not recommend lumbar punctures in asymptomatic individuals. The European guidelines suggest that you consider in people who are at high risk, so people with high CD4s, among people living with HIV, those with, I said high CD4s, high RPRs or low CD4s. Those are the people who are likely to have CSF abnormalities, but we really don't have an outcome study that tells us that those people do better. The CDC guidelines say there's no data to suggest that people with asymptomatic neurosyphilis do better if they're identified and treated. That's really because we have no data. So my suggestion is to discuss it with the patient and see how risk averse they are. In those people who have asymptomatic neurosyphilis are the people who can go on to develop symptomatic disease. And we see that. So if your patient is super worried, then and they have a high RPR or a low CD4, then I would go ahead and do it. But if they're willing to take a risk, and that's probably pretty small and can be followed, I think you could just treat them for their stage of syphilis, follow them with serology, and reserve an LP unless they have treatment failure.
Thank you. There is another question by Dr. Boy. It is asked if it is cost effective to evaluate for neurosyphilis in undiagnosed case of meningoencephalitis with CSF for both VDRL and FTA-ABS?
So that's a great question. So the VDRL, as we know, can be falsely negative in people with neurosyphilis, but it's certainly our gold standard. So if I were considering neurosyphilis in the diagnosis, I would certainly do that. The FTA-ABS we use to rule out neurosyphilis. So if it's negative, we say neurosyphilis is less likely. The problem with that, of course, is that most of the data has compared the FTA-ABS to the CSF FTA-ABS to the CSF VDRL. So some, like Dr. Ghanem at Hopkins, have argued that a negative CSF FTA-ABS should only be used to rule out neurosyphilis in an asymptomatic individual. So symptoms trump the FTA-ABS test in CSF. I think that the CSF TPPA titer could be really useful. The specificity is really high. And in a study that we did, we were able to identify additional individuals with neurosyphilis using that test who were CSF VDRL non-reactive.
Thank you. It's another question by Dr. Dorothy Shaha. She asks if in the treatment of neurosyphilis, the emphasis is on the usage of penicillin. And what do you do when the patients are allergic to penicillin?
So the guidelines suggest desensitization, but we've treated a fair number of people with ceftriaxone successfully. So I think that would be an option. Now, if they're truly beta-lactam allergic, you're in trouble. So desensitization would be the way to go. There is a high-dose oral doxycycline regimen, which is 100 milligrams. I think it's 200 milligrams POBID for 21 days. The problem with that is that there's not really a study to suggest it's useful. So I think if you were going to use that, you'd need to be sure the patient understood that it would be sort of experimental. But it should work, 200 twice a day. I think that some people use 100 twice a day, but I think 200 twice a day would be a better choice.
Mm-hmm. Thank you. As you show, about 5% of people that have syphilis will have symptomatic neurosyphilis. You showed also that there is a special strain of Treponema pallidus that cause more neurosyphilis. But do you think there are genetic predisposition to be affected by neurosyphilis, because it is a small proportion of people with syphilis that get neurosyphilis, and more. Why a few people get PGP or general paresis, and other forms, for instance, problems with
stroke or
vision or audition, and others have dementia. Do you think these are genetic, they are involved in genetic issues in these different kind of response to syphilis?
I think that's a great question. So we did publish a paper a few years ago looking at just 3 toll receptor SNPs, and showed that it was a TLR2, a TLR1, and a TLR6. These 3 individual SNPs conveyed increased risk for neurosyphilis. So I think it's really complicated. It's a combination of host genetics, factors related to the bacterium itself, and then probably related to the immune status of the individual. So if they have HIV, if they're being treated, if they've had syphilis before, which probably is at least partially protective. So I think there are a number of factors, but I think you're right that there are host genetic factors that make a difference as well. Great question.
Well, I think there is a last question. It is a question about a patient with syphilis who refused treatment, but then presents with a stroke. Would you treat him as neurosyphilis or thrombolysis if it is in a right time to this treatment?
So that's a great question as well. I've only been able to find 1 case report of an individual treated with thrombolysis, but I would certainly, if they were within the window, treat them. There's nothing, at least in the AHA guidelines, that suggests that you shouldn't treat a patient with meningovascular syphilis with thrombolysis or thrombectomy for that matter. But then I would also, of course, treat them for their neurosyphilis.
Okay, thank you very much.
Thank you, it's a pleasure.
Thank you.
National, could you take from here?
Yeah, any comments from Professor Joe Berger or Professor Raj Shakir, and then we move on to cases. Rahul Kulkarni, take over now.
Thank you, sir. So after these 2 wonderful talks, I think we move towards cases, and we are going to see hopefully some exotic kind of infection cases. So I would request Dr. Marco Medina to introduce Dr. Oscar Del Bruto, and then we'll go ahead with the cases. Professor Marco Medina.
Thank you very much. I would like to introduce my dear friend, Oscar Del Bruto. He was a former chairman of the tropical neurology group at the WFN. He made his residency program at the National Institute of Neurology and Neurosurgery in Manuel Velasco Suarez in Mexico City, as well as at the National Autonomous University of Mexico. He is the past president of the Ecuadorian Society of Neurology, as well as the Epilepsy League, Ecuadorian Epilepsy League against epilepsy, and then the Ibero-American Stroke Society. He has a very high scientific production with more than 400 papers published in peer-reviewed medical journals, 20 book chapters, and 3 books. He is the founder of the Revista Ecuatoriana de Neurología, and he's the editorial board member of Epilepsia and the Cerebrovascular Disease. He's a fellow of the American Academy of Neurology and professor in Guayaquil, at the Universidad Espíritu Santo. Welcome, Oscar.
Thank you very much, Marco. Thank you for the invitation. Can you hear me well?
Yes, we can hear you well.
Okay. First of all, thank you very much for the invitation. And I must say that I haven't been wearing a mask, but due to a second wave of COVID in Guayaquil, I've been in contact with several patients, and I don't want to expose my family, particularly my granddaughter who is moving around. So I'm using a mask every day, and sorry for that. Let's go to the talk. I'm going to present a very interesting and frustrating case that I saw a couple of years ago. And this case is an example of how difficult it can be to diagnose an infectious disease. It's about a 23-year-old woman who presented to other institutions because of a two-week history of progressive headache. According to the record, the neurological examination as well as the physical examinations were normal. Routine lab tests were unremarkable, with the exception of a mild increase in white blood cells. A brain MRI was normal, and she was discharged on headache medication. 2 weeks later, she was evaluated at another hospital because of progressive headache, somnolence, and double vision. The records say the neurological examination disclosed a right abducens palsy, but the ocular fondi were normal. ELISA for detection of anticysticercal antibodies in blood was positive. HIV was negative, X-ray films of the chest were negative or normal, and the new MRI showed small ring-enhancing lesions scattered over the brain parenchyma. And she was started on albendazole therapy at standard doses for 1 week. Despite therapy, clinical conditions worsened, and she developed progressive somnolence and low-grade fever. A specific interview by the attending physician disclosed that the patient climbed on the roof of her house 1 week before the start of symptoms because she heard some noises at the roof, like animals walking, and she found a lot of dust, spider webs, as well as some bats and rats. Spinal tap was not performed, and on that basis, she was started on empirical amphotericin B plus fluconazole, together with a combination of ceftriaxone plus vancomycin. 1 week later, neurological conditions deteriorated even more, and then she was transferred to our hospital. On admission, the patient was in stupor, only response to pain, but she was breathing by herself. Neurological examination disclosed complete ophthalmoplegia and fixed pupils, and there were bilateral Babinski signs. Ophthalmology consult disclosed bilateral papilledema. ENT consult was normal, dental evaluation was normal, CT of the thorax was normal. All these exams were performed at our institution. Transthoracic echocardiogram was normal, and detection of anticysticercal antibodies by immunoblood were negative. Blood cultures were negative, and an abdominal ultrasound was normal. Then I repeated the MRI, and at that point, I wanted to cry. I didn't know what to do. You can see hundreds of small brain abscesses disseminated over the brain parenchyma, and particularly in the brainstem. I have never seen before such a lot of nodules in the brainstem as this patient had. And take a look at the DWI and ADC map, and you see many hyperintense lesions in DWI, suggestive of abscesses, and hypointense lesions in the ADC map. I performed a spinal tap, and the CSF was slightly xanthochromic, but was not much revealing. There were 25 cells, mononuclear, 78 milligrams of proteins, 51 milligrams of glucose, and the rest was negative. All stains, all cultures, and all antigen determinations for fungi, bacteria, tuberculosis, and whatever you can imagine. So I don't know if I can make it interactive and to ask you now, what would you do as the next step at that point?
So one thing would be to start corticosteroids plus antitubercular treatment, empirically.
She was on corticosteroids from the start. Antituberculous drugs were never used. Yeah, because the cultures and PCR were negative. She was, at that time, treated with antimycotics and antibiotics. But she was doing worse and worse and worse and worse. And everything was negative so far, or unrevealing.
Was a cardiac evaluation done?
Excuse me?
Cardiac evaluation.
Yeah, transthoracic echocardiogram was normal.
Okay. Thank you.
I did that suspecting on
bacterial endocarditis.
Bacterial endocarditis, yes, as the cause of brain abscess. That's why I also called the ENIT, who said there were no problems in the ear. Dental examination was also normal. Well, we decided to go for a brain biopsy. We called the neurosurgeon, and he chose a superficial lesion located in the right side of the brain, and he resected one of these lesions. You can see here the bone flap. And this is the macroscopic appearance of the lesion, which to me looks like a granuloma or an abscess. However, microscopical examination was totally unrevealing. There were no caseating necrosis. There were no microorganisms. But all what we saw were an intense inflammatory infiltrate composed of polymorphonuclear cells. There were no giant cells, no Langerhans cells. So I guess that reasonable, the diagnosis of tuberculosis is out of question. After surgery, I started thinking in rare diseases. I thought about balamutria, amoebic cases, or even nocardiosis, mainly on empirical basis. So I withdraw antimycotics, and I started claritomycin, azithromycin, and metronidazole. Over the following days, the patient deteriorated. She entered into a deep coma, and this is the CT. There was acute hydrocephalus, and you can see here some bleeding in the ventricular cavities and in the subarachnoid space. But this time, coagulation parameters were getting abnormal, and she finally developed disseminated intravascular coagulation syndrome. Nevertheless, in view of the hydrocephalus and the deep coma of the patient, the surgeon went again and put a shunt and removed the bone flap and opened the dura. And he told me that the brain is squeezed like a toothpaste through the window. And 2 days after surgery, the patient died. And this is what the autopsy revealed. Hundreds of pyogenic brain abscesses. Microscopic examination was not revealing. No microorganism grew in different stains. So this is a case of multiple pyogenic brain abscess of unknown etiology, of unknown origin, that cost the life of these patients in about 30 days. As I told you before, this was a very frustrating case, and I would like to share it with you to hear some opinions about this case.
At autopsy, was the heart normal, or any evidence from the valves of infection?
No, the husband only allowed cranial cavity.
Oh, okay.
He did not allow a complete autopsy. But you know, that's what we saw in the brain. You can see here purulent material, pyogenic brain abscess, hundreds of them. Look at here, 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 over here. You see, there are many. I have never seen something like this before.
So was it possible to isolate any organism from it, some bacteria?
No, not really. We didn't isolate anything.
So what about the issue of listeria? So listeria causes abscesses in the brainstem, and many of the drugs you gave would not have covered for listeria, and it could be hard to culture and could have a prolonged course.
Yeah, I guess that the problem is that in the other hospital, they started antimicrobial therapy. So maybe this hide the real cause of the disease. Listeria is a good option, but personally, I have never seen so many abscesses in the brain due to listeria.
Yeah, I've only seen the brainstem. I've not seen it. But Joe Berger, if he's still on, I think he and
yeah, I'm still on.
Israel Steiner, you had that case that you presented at the AAN.
Yes, that's correct. So let me just, you know, it's interesting. I have a case now that I'm writing up where we did everything, including next-gen sequencing, where the patient kept having multiple pus pockets in their brain, and we were never able to find anything. We were never able to find an organism. He's still alive, he's doing very well, and we ended up putting him on anakinra, which is sort of like an anti-neutrophil drug. And he's done exceptionally well with that, and we have absolutely no idea. He's had very thorough rheumatologic evaluations. He started out actually with an episcleritis or conjunctivitis, and then became confused a couple months later, and subsequently developed a variety of problems, including a transverse myelitis. But it turned out to be pus pockets, and he was biopsied twice, and we were never able to figure it out. So, but I like Christina's thought. Your case is somewhat different than his, but I do wonder if there isn't an entity that has yet to be described where we may not find an underlying infectious cause, as I suspect in the patient that we're currently treating with anakinra. But I like Christina's thought that maybe this is listeria. It's a good thought.
With so many abscesses, the most possible reason is hematogenous spread. And we don't know from where it has come, but it is likely that it is a hematogenous spread.
You asking me?
Yeah.
Could you please repeat the question?
No, with so many multiple lesions in the brain, it is more likely to be hematogenous spread, either from the heart or the major vessel like aorta, some infection and going all over the place.
Yeah, right.
Are there abscesses in other organs too?
No, as I showed you before, everything else was normal. Abdomen, thorax, heart, ear, dental cavity, oral cavity. So we couldn't force a source of the infection. We couldn't found a source of infection. And the only antecedent, the only relevant antecedent was that the patient was up on the roof and there was a lot of dust and bats and rats. And that's why the other physician thought about fungi. And he started with antimycotic therapy, but antimycotic therapy didn't work. And besides, all fungi were negative in cultures at our institution. So listeria could be a possibility, right? But I have never seen so many abscesses due to listeria. I don't know, Christina, if you have seen something similar by listeria.
No, not that many.
No, I haven't either.
There were more than 200. I counted. More than 200 lesions. And you know what is important? It's important at the other hospital, they perform an ELISA for detection of anti-cysticercal antibodies, which was positive. And this only says the poor reliability of ELISA for diagnosis of this disease. The frequent cross reactions results and false positive tests make ELISA unreliable for the diagnosis of neurocysticercosis. And this made that the patient lost 1 week waiting for the effects of albendazole. Actually, this was not cysticercosis, by the way.
One of the things that we've done as a matter of routine lately is sending specimens of spinal fluid out to Mike Wilson at UCSF and having him do next-gen sequencing. And if you have some spinal fluid that you've put in a freezer somewhere, or a fridge, might be a good idea to send some out to Mike and see whether or not they can identify something. Now, I will tell you, we had a case recently, and he reports this in the New England Journal of Medicine in his paper in the New England Journal. We had a case of a young girl who had an unusual brain infection. We sent the specimens out to him. They were negative, but she proved to have an ascariasis, a form of ascariasis. The specific name escapes me, but it turned out to be a parasitic infection that was not detected by the next-gen sequencing. And about, I think it's on the order of 20% of his cases, they weren't able to sequence anything yet with other methods, other conventional methods. They were able to detect the infection.
I guess the lab should have the sample free, so I'm going to ask about that.
Someone suggested disseminated strongylosis, and she got steroids. Did she have a strongy serology?
No, yes, but negative. And also in blood, also in feces, negative, 3 times.
Okay, I give up.
Yeah, very interesting and great case. It's a mysterious case, I think, but we have to move now. Rahul?
Yes, sir. So I think from one good case, we move to another good case. Hopefully we'll see something more exotic this time. And then I'll ask Dr. Marco Medina to introduce the next speaker.
Thank you very
Dr.
much.
Silva. Thank you, sir.
Thank you very much, Oscar Del Bruto. This is a very interesting case that has to be evaluated. You know, the CSF could be the clue to make the diagnosis of this interesting case. Thank you very much, Oscar.
Thank you.
I would like to introduce the next speaker. This is Dr. Larissa Silva Teixeira. She's doing her neurology residency training at the University of Sao Paulo, Brazil. She got the award of the best oral presentation during the Congress of Cardiology in Bahia, Brazil, and the second best oral presentation during the Congress of the Cardiology Congress as well, and the best oral presentation during the Inter-American Congress of Emergency Medicine. Please, Dr. Teixeira, welcome for this case presentation.
Thank you, Professor. Can you hear me all?
Yeah.
All right. I share my screen. So good morning and evening and afternoon, everyone. Thank you for this opportunity in such a unique event, Professor Ricardo Nitrini and all the others professors. So now I will present an interesting but very challenging case that the neurology service conducted from the emergency department to the neurology ward. Also, I'd like to ask you to kindly interact with me during the presentation. Just answer a short question of a proposal. Just have to point yourself on camera and read the QR code and answer the question. So let's go. The patient is a 34 years old and an Afro-descendant man admitted to Hospital das Clínicas, São Paulo. His symptoms started on day 1 with a spontaneous thoracic back pain. On day 2, he had urinary retention with weakness on both lower limbs. And unfortunately, on day 4, he lost his ambulation capacity. On day 5, he had a progression of weakness with plagia on left lower limb and was admitted in our hospital. He referred to no previous symptoms such as fever, skin lesions, and his past medical history was remarkable by an acute persistent visual loss in the right eye, which was 12 years ago and was further diagnosed as ocular toxoplasmosis. He had no non-chronic medical conditions or sexually transmitted disease. On examination on arriving in emergency unit, his vital signs were normal, and his general skin, cardiovascular, respiratory, and abdominal were normal, but he had a bladder catheter insert. On his neurological examination, he had a completely normal cognition, but he had a flaccid asymmetrical paraparesis with a grade 2 of power on the right lower limb and a grade 0 on the left lower limb, with abolished deep reflex in both lower limbs. His coordination, he also had a superficial hyposthesia with a low level of sensitivity at T6, and his tip sensation was spared. His coordination was normal on upper limbs, and on his cranial nerves examination, we found a visual acuity of 20/100 on the right eye with an atrophic papilla, as we can see on the right. His meningeal signs were absent. He was submitted to urgent MRI scan, and as we can see, we found this hyperintense sign on the spinal cord from C5 to T9, and on the axial view, we can check this central medullary involvement. So we performed some initial investigations. On the very first day one, we collected cerebrospinal fluid, and we found the 63 lymphocytes, 9 monocytes, and 11 neutrophils. The protein level was high of 236, and the glucose was low of 23. The bile was negative. Also, we sent bacterial and fungal cultures for analysis, and also VDRL and FTABS, PCR-TB and cryptococcal antigen tests, PCR for herpes viruses, CMV, EBV, and enterovirus, and oligoclonal bands. In the blood, the cell blood count and the renal hepatic functions and the electrolytes were normal, but we also sent for analysis HIV and treponema pallidum antibodies, ENA, rheumatoid factor, and DNA, Pianca, Cianca, and ENA antibodies. We saved a sample for further research of entrecalparin 4 antibody. At that point, we had this clinical setting of a patient with a longitudinal transverse extensive myelitis, and he was a young after-resident man in a subacute presentation. Based on that, we made some hypotheses. Number one, neuromyelitis optica spectrum disease, but also other inflammatory or autoimmune disease with spinal cord involvement. However, we did have a concerning with his CSF, in which we found a pleostosis over than 50 and a hypoglucemia, which could prompt us to infectious cause hypothesis. So at that point, I'd like to ask you, what would you do? You just have to point yourself on camera and read this QR code. If you don't have a QR code reader, you can just type this address here, and that's as to check all other opinions. So what would you do now with this information that I gave you? That was everything you had available at that time. So you'd start pulsatherapy with corticosteroids, or you'd start plasmapheresis, or actually you'd be more aggressive and start pulsatherapy with corticosteroids plus plasmapheresis. Letter B, you'd start empirical antibiotics, or no, you would wait for CSF and blood results. So I would just give a bit of time. I have 15 seconds. And we check the answers. No register is needed, and it's completely anonymous. All right, so let's check. Let's see. Interesting. So we are quite a spread answer, but I would say that the majority would start pulsatherapy with corticosteroids plus plasmapheresis. I don't know if we were right, but we agree. And based upon the gravity of these myelitis, we decided to start pulsatherapy with corticosteroids, and we did this for 7 days. Also, we performed one section of plasmapheresis, one single section that was stopped for review of the case. And at that point, unfortunately, it was midst of pandemic and our hospital was completely mobilized to COVID-19 assistance. And then we had to move to another building in where we had some limitations with lab facilities. That's why we had to manage this case during a whole week with no other labs results. And after this treatment, unfortunately, the patient didn't get better. And then we decided to perform a new MRI, at this time with brain and spine with gadolinium. And again, we found this hyperintense sign on the spinal cord, longitudinally extensive with the central medullary involvement, but there was no anomalous contrast by gadolinium, as we can see here. And interestingly, we found on the encephalus flare this hyperintense sign in the B-temporal lobes, in the polar B-temporal lobes. As we can see on the coronal view and the sagittal view, with no restriction to diffusion, and no anomalous enhancement by gadolinium as well. So finally, on day 10, we got the late results from lab, and we found on sero antibody for treponema positive, which were biolized NCIA and VDRL 1/32. On CSF, we found FTABS positive and a VDRL of 1:1. We immediately started treatment for neurosyphilis with crystalline penicillin for 14 days. At that point, now before come up with the results and outcomes for this case, I'd like to ask for some expert opinion. What you think about this longitudinal extensive transverse myelitis, Professor Christina and all the other professors? Could we attribute the myelitis only to neurosyphilis, could neurosyphilis be a trigger for other inflammatory disease? Or if it is neurosyphilis and only neurosyphilis, what would you expect the results to be and the outcomes to be? I think you can, if you are available, you can discuss now.
Typing, but I'll just talk.
All right.
So the first thing is that if you want to increase your treponemal load, give a patient with syphilis steroids and no antibiotics. So it's not a good idea to give people with syphilis steroids if you're not going to treat them. So that's the first thing. And of course, you didn't know that. I guess the other thing is, could this be vascular and could this be meningovascular neurosyphilis? I think you can still get myelitis from neurosyphilis. It is pretty extensive, but I think I would start with the idea that it's neurosyphilis and go from there.
All right. And for how long do you think it would be the expectation for the answer to the treatment, Professor? I mean, in how long time?
I don't know if he's going to get better. I guess it depends on how much of that is edema and how much of it is tissue injury. So I don't know what happened.
Yes, Steve wants to make a comment. Steve?
Sure. It's Steve Lewis. I was struck by how anterior the cord problem was, and it looked a bit like a interspinal artery infarction, almost like the pencil sign. So raising the question of infarction, DWI, you can't always do it in the cord, but when you can, it's helpful, which helps support infarction. So I think this might be, I think we call it Huebner's arteritis, any kind of infectious arteritis causing an interspinal artery infarction would be something to put on the table. Similar to what Christina just said. Thank you.
Interesting. We don't have the DWI, but yeah, I will show the results and perhaps we could refuse this very point suspicion.
Any comments from Joe?
Yeah, so, spinal cord disease with syphilis, there's a huge spectrum of it. Years ago, Bob Davidoff asked me to write a chapter on it, just on spinal cord syphilis in his book entitled Handbook of the Spinal Cord. And it turned out to be the longest chapter in his book. And the literature went back to the very early days, and it included everything from a poliomyelitis type picture to syphilitic gummas to, of course, tabes dorsalis, which at one time was the most common manifestation of neurosyphilis, but we don't see it all that often, to a pachymeningitis that caused what was called herb spastic paraplegia. And I was just trying to think, I was trying to look for the book because I don't remember ever seeing a longitudinally extensive transverse myelitis. As Steve mentions, of course, a stroke of the spinal cord is something that one would need to consider. The thing that concerns me, however, is that he's got hypoglycemia, right? I mean, you had a low sugar, which you wouldn't expect necessarily from a stroke. So there's got to be some syphilitic infection or something else that's going on. And the other thing that I was thinking of is, could this be an autoimmune disorder triggered by the syphilis? But if that were the case, why didn't the corticosteroids make him better? I mean, you gave him corticosteroids and he didn't seem to improve any. So I guess this is going to turn out to be perhaps a vascular insult of the cord, and we'd probably have to take a better look at the MRI to see whether or not it is concordant with an anterior spinal artery infarction. The axial images might be very helpful in that regard, and an MRA, a spinal MRA, may be of some value.
Did he have preserved vibration sense?
Yes, he had. His deep sensation was completely normal.
Yeah, so that fits.
Indeed. So with no more mysteries, the patient actually started to improve and he did very well. On discharge, he had a power of 4 or 5. In bilateral lower limbs, he was deambulating with some help. His sensation was improving and he was undergoing intermittent bladder catheterization. All other research on cerebrospinal fluid and blood came up negative, which include oligoclonal bands, HIV, and anti-aquaporin antibodies for NMO negatives. Also, we performed a last MRI, and surprisingly, he had this great radiological resolution of that lesions. So in the cervical levels, we cannot see it anymore, this hyperintense sign. And also, he just persisted with this 2.5 centimeters lesion with a lateral involvement, as we can see. So despite we did not perform in the beginning, the DWY.
I can't see your slides.
No.
Can you share your screen?
Put the data on the screen, please. Put the data on the screen.
All right, I will share again. So you can see now. All right. So the slides for the recovery, all other research, right, came up negative, such as oligoclonal bands, emphasizing the anti-aquaporin 4 antibodies in HIV as well. Everything else came up negative, and this is the result. So this is the very last MRI. Is this I'm showing now, and he had this complete resolution of the cervical level spinal cord lesions, and he just had this 2.5 centimeters lesion on the thoracic level with the lateral involvement, as we can see. And this is the before and after treatment comparison. So this patient with this longitudinal extensive transverse myelitis treated before treated with both therapy and plasmapheresis, plus after realizing it was neurosyphilis, we treated with penicillin, and we can see the before and after all this treatment. So perhaps we had some learning points that in a LETM, the CSF doses in hypoglucuremia may prompt the consideration of an infectious cause. Hypersign temporal lobes should expand the diagnostic possibility for neurosyphilis, something the professor mentioned before. And LETM can be a presentation form of syphilitic myelitis, and only the practice of serologic testing for syphilis in all patients with myelopathy may diagnose this potentially treatable disease. Thank you.
So what do you think the pathogenesis of this disorder was? I mean, how did it, what was it due to?
So honestly, I think he had neurosyphilis.
No, I understand that, but what did the neurosyphilis do to affect the spinal cord, and why did it improve as much? Is this edema that we're seeing that has just gotten better, or was this inflammation that has gotten better over time? What do you think has happened?
That's the point, because if it is only an inflammatory disease, such as an MO, for example, we don't really much repeat MRI scans. So, and afterwards, the lesion can really disappear. But could be only a trigger for this autoimmune anti-inflammatory lesions that we didn't get with the anti-aquaporin 4 antibodies. We really don't know when we're following up this patient. This case was actually from the beginning of this year, so we're still following him and see what will happen. He's till now is getting better results.
Well, I want to add that I asked Larissa to bring this case because I think it's very interesting. Because of course, the patient has neurosyphilis, and he also had longitudinal extensive myelitis. And what is the relationship between both? This is the main fact, the main problem in this case. At the end of the case, he improved a lot, and there was almost a resolution, almost complete resolution in the MRI. I think this is the main point, to consider that neurosyphilis was not the main cause of this disease, because as far as I know, the problem in neurosyphilis, in myelitis and neurosyphilis, are not do respond, but not so fast as it occurred in this case. But of course, we want to know from you, from Christina, from Joseph Berger, what they think about this opinion.
Well, the residual lesion looks like a stroke. I mean, it's respects the midline, it's a little wedge, goes out to the edge. So I think I agree with Arun, who said that he thought it was meningovascular syphilis and that it was edema. And he is really lucky.
Yeah, I would agree with Christina. I think that there was a vascular component, and this is a meningovascular event. There may have been some myelitis as well. And in fact, I just Googled longitudinal extensive myelitis with syphilis, and a paper by Desai came up from Anand, India. They presented it at the World Congress of Neurology, and they found 11 cases and attributed it to syphilitic meningomyelitis. They report one of their own with a story that sounds fairly similar to what is presented today. So this occurs, I just mentioned one other thing. The patient had a history of toxoplasmosis involving his eye. And of course, he was immunocompetent. There are rare cases of longitudinally extensive transverse myelitis that have been reported with toxoplasmosis as well. And you don't have to be HIV infected to get it, although I've seen toxo in the spinal cord in the HIV infected population. I don't remember ever seeing it in an immunocompetent individual.
Well, because as I originally thought that the main problem in neuromyelitis, in the myelitis of neurosyphilis, would be caused by vascular changes, what would be very uncommon to improve in the MRI as we noticed in this case. But of course, as you said, there are more cases with this evolution and this data in the recent literature. So we need to go ahead and to find it and to try to understand our case in a better way. Thank you.
I have one question. Have you ever seen schistosoma of the spinal cord producing something like this? Schistosomosis?
Schistosomosis? Yes.
Schistosomosis, yes.
Yes, on a series from our service from Dr. Samira Apostolus, she studied only longitudinal extensive transverse myelitis, and she found that the majority of cases, because it's really endemic here in Brazil, and the majority of cases of infectious cause was caused by schistosomosis indeed, if we count the infectious cause. But neurosyphilis in her series of case here from our service, which was 150 patient, she found 2 neurosyphilis patients with neurosyphilis in this presentation of an longitudinal extensive transverse myelitis.
Did they recover really quickly like yours did?
No, that's why it was really surprising in this case, because it was really fast. And I wouldn't expect this if it's just an infarction from the imaging.
It is really fast, you're right. It's a great case, great presentation.
Yes, terrific.
Thank you.
Yeah, thank you very much. I think we had a very interesting session, very good cases and very good talks. Next week on 24th, we have another interesting session. Professor Tamuna will speak on nosocomial infections of the nervous system, and Dr. Lara Benjamin will speak on stroke and infections. And there will be 2 interesting cases. And I would like to thank Professor Marco Medina for organizing the session and being with us, and Professor Cardoso, Professor Christina, Professor Joe Berger, Professor Steve Lewis, Professor Oscar Del Bruto, Dr. Larissa, Dr. Katrak, Dr. Raj Shakir, Rahul Kulkarni, Dr. Gagandeep Singh Charu, and of course, Dr. Kailash Bhatia. Thank you very much for being with us today and enlightening and interacting. And it was a very interesting session and another great session in this series. Thank you very much. Thank you all.
Thank you for the invite.
Thank you.
Thank you.
Thank you.
Thank you all.
Bye-bye. Take care.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Thank you, Ricardo. Thank you very much. Thank you, Charu.
Bye-bye.
Thank you, Ricardo. Thank you very much.
Thank you.
Thank you, Pramod. Thank you, Gagan. Rahul, thanks. Larissa, thanks. Very interesting case.
Thank you, Professor.
Thank you.
Thank you for the case. Thank you. Thank you, sir. Thank you.
Thank you. Good for the
yeah
session.
Yes, sir. Yes, sir. Thank you. Thank you.